Welcome. In this lecture, we'll be discussing secondary headaches. There are two different groups of headaches. Primary headaches are headache disorders that occur independently, meaning they're not caused by another underlying medical condition. These are typically diagnoses of exclusion, meaning you must first rule out secondary causes. In contrast, secondary headaches are a symptom of another condition, such as infection, bleeding, tumors, or even elevated intracranial pressure. Secondary headaches require urgent evaluation to treat the underlying cause. In this lecture, we'll be discussing secondary headaches, as primary headaches will be discussed in another video. Now, as already mentioned, secondary headaches are caused by another medical condition, and these headaches usually present different from prior headaches, as some of these individuals may have primary headaches at presentation, such as migraines or tension type headaches, but this presentation will be different compared to their usual presentation. And these headaches are typically associated with other red flag signs. Now, those red flag signs can be remembered with the 2 SNOOP4 criteria, which is a mnemonic used to identify red flags that suggest a headache may be secondary to an underlying condition rather than a primary headache. It has 2 S's in the mnemonic and 4 P's. The first S stands for systemic symptoms such as fever or weight loss. The second S stands for secondary risk factors such as malignancy or immunocompromised state. The N stands for neurologic signs or new onset focal neurologic deficit. If you have a headache that's sudden in onset, aka the worst headache of my life, always think subarachnoid hemorrhage. A new headache in an individual above the age of 50 years old or an older age at onset of new headache is concerning. If the headache pattern has changed, meaning that they have a history of migraines or tension type headaches, and they have a new presentation, that's also concerning. Papilledema indicates elevated intracranial pressure, must be worked up further. If the headache is positional, meaning it's worse with cough, valsalva, standing, lying flat, that also needs to be worked up. And then, of course, headaches that occur during pregnancy or postpartum should be evaluated further. Now, when none of these features are present, it supports a diagnosis of primary headache by lowering suspicion for secondary causes. However, if any of these red flags are present, further workup with neuroimaging, labs, or even sometimes lumbar puncture is needed to rule out dangerous underlying pathology. Now, the headaches that we will be focusing on in this lecture will be these 5, but there are other high-yield headaches to know for test day, such as subarachnoid hemorrhage, meningitis, and brain tumors. These are not covered in this lecture, but are covered in their own lectures. Now let's begin by talking about medication overuse headache, aka rebound headaches. This is due when the brain becomes dependent on medications to stop the pain. Essentially, repeated use of analgesics leads to 2 things: downregulation of pain inhibition and upregulation of pain sensitivity, also known as central sensitization. This means that the brain becomes dependent on the medication, and withholding it triggers pain, creating a vicious cycle. Thus, lack of the medication leads to an increase in pain sensitivity. Rebound headaches are classically seen in individuals with a known primary headache, such as tension or migraine types. Essentially, your brain expects the drug to stop the pain, and when it's not there, it overreacts with more pain. Now, rebound headaches are associated with a lot of different medications, but some of the classic ones will be triptans, such as sumatriptan, NSAIDs like ibuprofen, acetaminophen as well. Even in some cases, opioids can cause it. The first 3 here are classically used in the treatment of primary headaches, specifically migraine and tension type. And abusing these medications will lead to something known as rebound headache. Now, the presentation typically follows a common trend. This is more common in individuals with tension or migraine headaches, and occurs in individuals who are abusing those medications, ibuprofen, Tylenol, etc., greater than 10 to 15 times per month for more than 3 months. This is not something that occurs just overnight. It takes time to have this central sensitization form. You may also see other symptoms such as irritability, nausea, even memory issues. This is just secondary to the headache. The diagnosis is going to be clinical based off of this classic presentation, and the treatment is to discontinue the medication causing the issue and look for other options of treatment. Please note that in real clinical practice, it takes at least 3 months of withdrawal from these medications to see a significant benefit. Hence, it takes 3 months of treatment and 3 months of withdrawal to go back to baseline. The next headache we'll talk about is idiopathic intracranial hypertension, also known as pseudotumor cerebri. This is believed to be due to a impaired CSF absorption, which leads to an increased intracranial pressure, typically without a mass or hydrocephalus. Now, the true pathology is not well understood, but for exam day, it is important to know that it is believed to be associated with reduced CSF absorption. Now, there's a large multitude of different risk factors. We classically see IIH in young females, obese individuals, and individuals on oral contraceptives, especially those that are on estrogen-based, as all three of these are thought to be due to hormonal control, as estrogen is thought to impair CSF absorption. There are other medications that can cause this, such as vitamin A excess. Typically, this is tested as isotretinoin. Isotretinoin is a retinoid derived from vitamin A and is well known for increasing the risk of IIH. And this is thought to be due to the fact that high vitamin A levels disrupt the CSF dynamics and actually can lead to an increase in CSF production. Other medications, such as tetracyclines or donazil, can also cause CSF absorption issues. Of note, donazil is classically used in endometriosis, and that is also high yield to know for exam day. A mnemonic used to remember these risk factors is female toad. How this is more common in females, T for tetracyclines, O's for obesity and OCPs, especially estrogen-based ones. Vitamin A, remember vitamin A is also isotretinoin, and of course donazil. As a classic presentation, most of this presentation is related to increased intracranial pressure. The patient will usually be an obese female of childbearing age, maybe on OCPs, but does not have to be. The most common symptom that we see will be headache. Now, the headache is caused by stretching and irritation of the pain-sensitive structures, such as the meninges. This typically is diffuse, throbbing, unilateral, and even pulsatile. And because it's related with ICP, is typically worse in the morning or while lying down. You may also see pulsatile tinnitus or ringing of the ears. This is because increased intracranial pressure transmits pressure to the venous sinuses. This leads to turbulent blood or turbulent venous flow that's perceived as rhythmic, and it gives you a whooshing sound. Other symptoms due to increased intracranial pressure will be nausea, vomiting. You may get double vision or diplopia, and this is classically caused by cranial nerve 6 palsy. This is a classic nuclei that is affected in the brainstem due to increased intracranial pressure. That is the reason you have double vision in IIH. And the hallmark for this disease will be something known as bilateral papilledema. Papilledema is also seen in elevated intracranial pressure and is demonstrated as blurred disc margins and optic disc swelling. This is typically seen on an ophthalmic exam. So here's a typical eye. And of course, this is what you want to be on the lookout for exam day. You can see that we have these blurred margins. You can't really make out what's going on. And of course, there's some sort of swelling here of the optic disc as it is much, much wider. That is classic for papilledema. Now, the diagnosis is clinical, but is supported highly with imaging and further workup. So these tests need to be ordered. The first thing we typically start with is MRI brain, MRV. This is always done first to rule out other structural causes of increased intracranial pressure. This must be done first and is usually normal. We don't really see much changes. Now, the best test in order to diagnose this, the gold standard, will be lumbar puncture. This is only done if there are no signs of increased structural ICP, such as tumors, masses, something along those lines. This is the most accurate test for IIH, and diagnosis is based when the opening pressure, so the pressure we get as the lumbar puncture goes in, is greater than 250 millimeters or 25 centimeters of water. The rest of the CSF findings are typically normal. Now, if not already done, we also need to get an ophthalmic exam to look for papilledema, as well as other damage to the optic nerve. But for the exam day, this will be your gold standard option for IIH. Now, the treatment will be first to stop whatever potential medications are causing this. So OCPs, isotretinoin, donazil, tetracyclines, etc. Anyone with a BMI above 30 should undergo weight loss. This is key, as obesity is a high risk factor for IIH. And of course, from a medication standpoint, we're looking for carbonic anhydrase inhibitors. Our gold standard will be acetazolamide, but if an individual has a sulfa allergy, we can always use topiramate as well. And this decreases the production of CSF. It is also important for test day to know that CRLPs are no longer part of treatment. We used to do this, but to drain the fluid that was not being drained appropriately, but actually the production of CSF in the body is greater than what we are able to drain with an LP. It is also not recommended for patient discomfort purposes. Now, the biggest risk factor or complication of IH is blindness. Now, surgical treatment can be indicated with an LP or venous shunt only if this criteria is met, any one of these. So you have signs of vision loss, you have refractory headaches, refractory IIH that's not responding to this treatment here, and of course, if you have change of visual acuity in the setting of papillary edema. For the purpose of your exams, number 2 is the one that is most commonly tested. The next secondary headache we'll talk about is something known as cerebral venous sinus thrombosis. This is a thrombosis or a clot that forms typically in the dural venous sinus, which is the veins that drain blood from the brain. This leads to venous outflow obstruction, which causes an increase in venous pressure, impaired CSF absorption, and can lead to an increased intracranial pressure. This is thought to be secondary to a hypercoagulable disorder and leads to some sort of outflow obstruction. Thus, the risk factors associated with cerebral venous sinus thrombosis is all going to be secondary to hypercoagulable states, such as pregnancy, OCP use, especially estrogen-based OCP use, so just like IIH, individuals with malignancies or cancers, and of course, genetic factors. Just know that sometimes infections like mastoiditis or otitis media can cause cerebral venous sinus thrombosis, but for the most part, it is more believed to be associated with some sort of hypercoagulable disorder. Now, the presentation is also going to be secondary to ICP. Now, the most common symptom is going to be headache. This headache, as well as sometimes visual changes or visual disturbances, are caused by ICP. Thus, they're going to be worse with lying down or even with Valsalva. The headache, again, results from stretching of the pain sensitivity structures, which irritates the meninges and causes symptoms. The visual symptoms occur when elevated ICP actually compresses the optic nerve, leading to papilledema or even sometimes blurry vision. Other changes that we may see are seizures or even sometimes focal neurologic deficits. This is classically seen in a very young female who's either pregnant or on some sort of estrogen-based OCP. Now, the diagnosis, like IIH, will start with, and the gold standard will be, in this case, brain MRI and MRV. That is the gold standard diagnosis for cerebral venous sinus thrombosis. And classically, what you will see as the MRI-V here gives us the venous system, you'll actually see a sinus thrombosis. Now, patients should also have a hypercoagulable workup with protein C, protein S, antithrombin, factor V, and antiphospholipid syndrome should also be worked up. Now, because this is thought to be due to a hypercoagulable state, the gold standard treatment is going to be anticoagulation. We typically start with IV heparin, and then we try to bridge to warfarin. And the minimum treatment for these individuals will be 3 to 6 months. Now, another high-yield secondary cause of headache to know is giant cell arteritis. This is a granulomatous vasculitis that primarily affects large and medium-sized arteries. It typically affects the external carotid artery and its branches, such as the temporal artery, which is the most commonly affected, but sometimes even the ophthalmic or vertebral arteries can be affected as well. This is driven by the CD4 plus T cells as well as macrophages, and this leads to giant cell formation, which leads to arterial wall damage and ischemia. This is commonly associated in individuals above the age of 50 years old, as GCA is the most common vasculitis in this age group and is classically seen in females. It is also highly associated with another autoimmune disease known as polymyalgia rheumatica, which is bilateral shoulder and hip stiffness, not weakness, stiffness and aching, especially seen in the morning. Now, giant cell arteritis will have a classic presentation as well. Headache, which is typically seen in the temporal area and is described as pulsatile. Sometimes even when you palpate it, you might also feel this pulsation. Now, the most specific symptom is going to be something known as jaw claudication. This presents as pain or fatigue in the jaw muscles while chewing. And this is caused by ischemia of the masseter muscles due to the temporal artery involvement. You may also, again, see polymyalgia rheumatica, which we've already talked about, stiffness in the upper extremities, specifically in the morning. And of course, because this is affecting the temporal artery as well as potentially the ophthalmic artery, you may see vision changes, such as amaurosis fugax, which is a transient, painless loss of vision in one eye. This is typically described as a curtain coming down over one's eye and is only temporary retinal ischemia. On the contrary, you might also have anterior ischemic optic neuropathy, AION. This is sudden, painless, and usually permanent vision loss, and this is caused from ischemia of the optic nerve head. This is classically seen in giant cell arteritis and is something that we want to prevent. Now, the diagnosis is going to be mostly clinical, as you should typically see elevated inflammatory markers such as ESR or CRP. Now, please note that the diagnosis is confirmed with temporal artery biopsy, which will show giant cells on it. But it is important to know for exam day that we do not delay treatment waiting for the gold standard temporal artery biopsy. So although that is the gold standard, we do not delay treatment. The treatment for this disease should be initiated as soon as GCA is suspected, and that is going to be with high dose. High dose is key, not low dose, as polymyalgia rheumatica is typically treated with low dose steroids. Giant cell arteritis is going to be treated with high dose steroids, which are first line. Typically, we use IV steroids if there is vision loss, and if there is no vision loss, it is okay to give oral, such as prednisone. Now, there is a high yield complication with GCA, as you can sometimes get aortic aneurysms. Because of the chronic granuloma's inflammation, this weakens the elastic and muscular layers of the aortic wall. This leads to damage of the vessel's media. So this structural weakening causes loss of tensile strength, which can then lead to aortic aneurysm production. Typically, we see this in the thoracic area, as depicted in this image here. It is large thoracic aneurysm. Because of this, patients should typically undergo serial chest imaging, usually with X-ray, but sometimes you can use CT scans as well, but X-ray should be sufficient. The last one we'll talk about is brain abscess. A brain abscess is a localized collection of pus within the brain parenchyma, typically resulting from infection from bacteria, fungi, or even sometimes parasites. It usually begins with cerebritis, an area of inflamed brain tissue, which then progresses to this walled-off abscess. So the most common bug that causes this will be Streptococcus, but please know that there are other causes, such as Staph aureus, Staph epidermidis, and some gram-negatives. What we classically seen is polymicrobial causes of brain abscesses. Now, the risk factors are going to be underlying other infections. Classically, otitis media, which can then spread to the brain, mastoiditis, which is similar to otitis media, sinusitis, especially with the ethmoid or maxillary sinuses, dental abscesses, and of course, congenital heart conditions, or even sometimes endocarditis can cause brain abscesses. Now, the brain abscess presentation is going to be an individual who just got over some sort of illness that was just listed on the slides prior. Now, again, the most common symptom is going to be headache. This headache is going to be caused by increased intracranial pressure. So the red flags are going to be worse in the morning, worse with Valsalva, worse with coughing. And this typically is going to be dull, that gets worse over days, if not weeks. Because it is an infection, we also classically see fever. We actually only see this in roughly 50% of all brain abscesses, but it's something that is classically given to you on exam day. We may also see other systemic symptoms, such as chills, fatigue, malaise. Now, depending on where this brain abscess is, you may see other focal neurologic deficits. Again, the occipital lobe may present with vision changes, the frontal lobe may present with motor changes. It all depends on where the abscess is. And of course, seizures as well. Now, the diagnosis is going to be with an MRI of the brain. This is the gold standard in diagnosis. Now, if this is contraindicated, maybe sometimes because of metal in the body, a CT scan of the brain can also be a backup just in case. And classically what we see is at least greater than one ring-enhancing lesion with central necrosis. So this is a classic image that will be provided for you. This ring around the central area of necrosis seen on this image. Now, the treatment is going to be IV antibiotics. Typically, we give a third-gen cephalosporin, such as ceftriaxone. Classically, also treated with metronidazole and or vancomycin if we think staph is playing a role here. Now, like most abscesses, sometimes we need to drain brain abscess. But there is some criteria. So if the abscess is greater than 2.5 centimeters or there are signs of increased intracranial pressure, this will all be indications to drain. If the abscess is less than 2.5 centimeters and there are no signs of ICP, then we can get away with potentially only using IV antibiotics. Here is a table summarizing what was discussed in this lecture, and that concludes this lecture on secondary headaches.